We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the Healthcare Revolution podcast. Today we have with us Elizabeth Lane, who is a legend in our profession here in Utah. If you know her, you love her. She has been a professor at the University of Utah for I don't even know how many years, but she is a remarkable teacher at teaching future physical therapists on how to be great physical therapists. She is a doctor of physical therapy. She's a fellow, which means she has advanced certifications and training to be able to get to a higher level. And then she also has a PhD. But what I love about her the most, on top of that education, is she is a CrossFit athlete. She's one of the top athletes in the world. And it is incredible to see people go to the CrossFit Games, go to the quarterfinals. And she was a competitor last year. And we're so excited to have her on the podcast. So welcome, Elizabeth.
Oh, thanks so much for the great introduction, Brad.
You're welcome. I'm so excited to have you here.
And I'm so excited to be here.
I remember just in class 6 years ago when you were teaching me, and I was just, the enthusiasm, the clarity on what you taught was just incredible.
I really appreciate that. The passion just shines through, right? Like, you care about these things. You know, we always go back to our big why, like, why are we doing this? Mm-hmm. And mine is to get patients better. And that means getting our students better, getting our clinicians out in the community better to get our patients better.
Yeah. What I loved about what you did the most is you just broke down things so simply. You took something very complex on the way that we studied it and the way we read it in the textbook, and you would just show us. I remember one thing in particular, showing us how to adjust or manipulate the spine by popping it, right? And you just showed me one step, right? You just pivoted your foot to the left, rotated, and that it was there. And it was something that we way overcomplicated, and you just provided so much clarity.
Yeah, I think that it's a function of the way my brain works. Like, I have to understand things pretty well to understand the simple parts. And so that really helps me break it down for other people. So I'm glad that works for other people.
Yeah, I was just at the University of Utah with some third-year PTs doing a guest panel. And I asked them, does anyone know Elizabeth Lane? And they're like, oh yeah, we know her. And everyone just raves about you. So you do incredible work, and you've really taught hundreds, probably even close to thousands of PTs now out in the community. And you've taught them to be amazing physical therapists. So thank you for what you do there.
Oh, I appreciate that. It is all about, that why. And it's great to get some validation on that, from amazing clinicians like yourself.
Well, thanks. Well, today we are talking about kind of the additional factors that we need to consider with low back pain. So people have gone in and they've done what we call the biomechanical, which is like the way that you move. Maybe we're strengthening certain muscles. Maybe we're getting more mobility through a certain joint, right? Those things that we focused on, and maybe they're still not getting better. So we call it the contextual factors of low back pain. But before we dive into that, let's just briefly talk about, you've dealt with back pain, probably yourself, and then also with a ton of patients through the years. You're an absolute expert in this area. What are the main reasons that you see within a clinical setting for people having low back pain, and research as well?
Well, I wish I had a one-liner on why people get low back pain, and there's no one in the world that does have that answer, because it's so multifactorial. It is a little bit of this, a little bit of that. It is I've been operating in this way, moving in this pattern, or I've lost a little sleep, I have a little extra stress in my life. And then all of that, we can talk later about how our nervous system processes those signals to interpret all of those to be pain. And that is really where the the problem occurs, is that it's not one thing, unfortunately.
Yeah, what's so amazing to me, back pain has been my just like love, my true love. If there was to pick one region, obviously we're talking like we treat humans. We don't just treat body regions, right? But if there's any injury that I really love treating, it's low back. And what I've definitely understood as I've worked through it more with now thousands of patients is that what you're saying is true. That the more I learn about it, the more I realize it's not just the mechanical factors. There's so many factors to consider. Just like you were talking, like sleep. What does your sleep look like? What does your mental health look like? What does your nutrition look like? These things add up, and the body essentially keeps score. And then one day you have back pain. And it wasn't just because you moved wrong that one time. It was the combination of all these factors coming to this one day that's led to that. So our goal today is to try to simplify as much as we can and give tips for our listeners on what they can do to look at these other factors. But let's talk about the biomechanical factors. What are some biomechanical factors that people should consider?
When we really think about where our clinical practice guideline is, that helps us like distill a lot of evidence that's out there for low back pain. We put people in these groups, basically, to treat them. We have back and leg pain, and we have some...
And people might know that as radicular or sciatica.
Yeah, and we have more movement-based therapy to help reduce that leg pain. And so instead of putting a label on what is wrong, we really place that label on how we help people. We can talk for hours and hours about the non-utility of imaging for low back pain and identifying one particular structure in the low back. And we can talk for additional hours about how we can still help those people. And by having some of that imaging, it even hurts our patients because it hurts our mindset, and it hurts us as clinicians because we get kind of tunnel vision on, oh, this must be the thing that's wrong because that looks like it on imaging. So all to go back to say, really when we think about back pain, we put them in categories that we can treat them. So back and leg pain, we do some specific movements to help that. They may have some mobility deficits. That's where our hands-on treatments are really helpful. They may have some...
So joints might be really stiff, and we use our hands to improve that motion.
Absolutely. And then we have some like motor control deficits where our muscles are not functioning as good as they could, whether that's a strength or a coordination deficit that they may have. And
so we essentially take them through some movements to improve those patterns of movement.
Absolutely. So those are kind of big
which is so cool that we have these clinical practice guidelines, because something has to guide our thought process, right? We got to have some sort of categories or patterns that help funnel people into a certain type of treatment, right? And we just know, okay, based on our tests, you would be best for this category of treatment, right? But that doesn't necessarily take away from treating the whole body, right?
Oh, no.
This is just one factor that we treat, and we'll go through and retrain. But all these factors add up to a term we called pain neuroscience education. Tell us what define that for us. Pain neuroscience, PNE, right? We use that term quite a bit in the PT world. Define that for us.
Yeah, so the neuroscience of how our body processes pain goes through our central nervous system. So basically like your central processing unit, like your main computer, mainframe. All of these signals are coming up from our periphery, our hand, our low back, and it's saying stiffness or inflammation or something like that. And then the central processing unit is saying, oh, that's a threat, aka that is pain. So it's basically a really, really fancy alarm system, right? Where it's taking this information and then it's putting an output. Ooh, threat. Don't like that. So we're going to make that pain.
Yeah, my daughter, Emerson, she's 8 years old, and she's reading this book on pain neuroscience.
Oh.
And she described it to me, what she read, as a spider web. So there's this threat, which is maybe something that gets caught in the web, and the web moves around and gives the signal to the spider. So she's explaining this to me as an 8-year-old. I'm like, that's brilliant, right? Well, she read it in this book, right? But it's so important for everyone to understand how pain works. It is an alarm system, right? I saw this post the other day that has this check engine light on their dashboard, and it says certain athletes get a marker and just black it out like they don't see that check engine light. And most of the time, pain is just a check engine light. Doesn't mean that your transmission went out or something blew up, right? Or that you need to get an MRI. Most of the time, it's just you need to check on a few things.
Yeah, you may need to check on a few things. When we talk about chronic pain, it's really that the light itself is the problem, that it's saying to check something and nothing's actually super wrong in the periphery, in your low back, or in your transmission.
Yeah, like the light's on, but literally there's nothing actually physically wrong. It just gets stuck on because it's stayed on for so long. So we'll talk more about that. I love that conversation because a lot of people just think like, oh, it's just the way I move, or it's just my weakness, or I'm just stuck in this because my genetics. Everyone has back pain in my family, but ultimately there's so many things that people can do. And we'll dive into that more. Any other mechanical things that we should discuss before we get into these other factors?
We, in physical therapy and healthcare, we have vilified a lot of imaging that happens. So, and I know we spoke about that earlier, but we can also vilify, certain things that are going on where this is not moving as well as it should. And we kind of ruminate on and really focus on those things and can't really not focus on those things anymore.
We get that tunnel vision that you're talking about, right? It's like we just get hyper fixated, like we're just super focused on that one thing when there's so many other things we need to consider.
There's so many other things that will help that patient get a lot better. And as patients, we also should not focus too much on just one thing, like, oh, I really have to brace before I pick up this pencil off of the floor. And that's really not. Our system is so much more resilient than that. So.
For sure. Yeah, I remember when we did human dissection in the anatomy lab and we took out a disc from the spine. And obviously this is a cadaver, right? A passed on body. And the disc may have solidified a little bit more. But I remember I took the scalpel and I was just like trying to get the scalpel to go through a disc. And we describe it as this jelly donut so often. It's like, that is not how a disc is. If you've seen a disc, and I've also seen it surgically in a live human, it is not a small thing. Like they literally have to chomp at that to do a microdiscectomy, which is removing part of the disc. And they use these heavy, sharp tools to do it. But yet in our minds, we envision it this jelly donut because that's how it's prescribed, or that's how people talk about it, that it just, you push one wrong way and it just bursts everywhere, right? But ultimately, discs are extremely resilient. There's other factors that are causing your pain most likely.
Absolutely. Great point.
Tell me about let's just kind of go through a list of other factors to consider other than just the mechanical factors.
That's a great question. Really, when we think about, and this can overlap a lot with wellness and health, and that doesn't mean that we're taking some sort of cop out and we're saying, oh, it must be all these other factors, because these factors actually matter probably a lot more than our biomechanical factors, and that being our nutrition, our sleep, and our overall exercise and movement. So those being the big three.
And mainly with exercise and movement, you're probably alluding to consistency, frequency.
Absolutely. I am not telling people that they have to go out and run marathons. We are not trying to do that. That is not where you have to be to gain a big portion of health. Yeah. It is your 10,000 steps a day.
Yeah, absolutely. Because I think most people with exercise is they'll go through these waves where they won't do anything for a really long time. And then they'll get back to the gym and do something really hard or really heavy or a ton of volume or a ton of reps. And then they get hurt and they're like, well, exercise isn't for me. But it's purely about probably the volume and the consistency or inconsistency at that, right? But I'm going to stop us here because I want to record that. what are your top things? I'm going to ask the question again here in a second, but what are the top things, the contextual factors? Okay, what are the other things we need to consider? You said, you said sleep, nutrition, exercise. What'd you add
Movement.
to that? Exercise, movement. Is there anything you'd add to that list?
I don't think so. I think that those are the
Big three.
biggest things. Yeah.
Yeah. Okay. So tell me about the other factors that people need to consider when it comes to low back pain other than just mechanical.
Yeah. The big three things here are just overall health things. And so that being nutrition, your sleep, and then exercise/movement.
Okay. Yeah, all three of those, I think a lot of people neglect. It's like, now I'm getting 6 hours of sleep, but I'm going to go exercise every day. What are the things that people need to consider with sleep?
With sleep, just that we're getting enough of sleep, that we're getting restful sleep. It takes a big portion of our day, right? It's the thing that we should be doing the largest portion of our day. So most people need 7 to 9 hours of sleep, and that's where they're kind of 8.
I wonder how many people are getting
on average. Came from. Yeah. And
how many should young adults be getting? How many hours? Like teenagers?
Younger adults.
Teenage athletes.
Even plus 9, right? Yeah. So 9 plus.
Yeah, and I think a lot of people are not getting that, and that's something that we definitely need to consider. How does sleep play into back pain?
Well, sleep plays into back pain and just our overall health as it's our recovery, right? So this is where our brain gets to shut off and recover. All of our natural processes of recovery happen while we're sleeping, right? So, that person who goes out and trains and then only sleeps 5-6 hours is, they're breaking their body down during that exercise, which is the natural process of what we should be doing during exercise.
A lot of people think that you're actually building it up.
Yeah, that's right.
But really, when you strengthen a muscle, say you're doing strength training, you're actually breaking the muscle down, and the sleep is actually recovery. What a lot of people are doing nowadays is like, oh, it's all about the saunas. It's all about, the recovery boots. It's all about all these other things, when sleep is just the natural way to get recovery.
Yeah, and I don't really know a percentage of like what recovery and what those other things are, but sleep is the biggest. I would venture to say like 80 to 90% of our recovery, and sauna is like 1% to these other things.
We get so obsessed with these other things, and it's like, no, 80 to 90% you can just get from sleep alone.
It is free. Right.
Yeah,
we hear we get so many elite athletes talking about what did you do to really break through this plateau? And, there's this famous cyclist, and I don't remember the name at this moment. And they're starting to excel, and they're like, gosh, what did this guy do in the off season? He's just like, I started sleeping.
That was the secret. I slept. That's what happened. I love that.
That was it.
It'd be so cool if a lot of athletes started talking about that. It's like, I just fell asleep. I got 8 hours of sleep every night. I really owe it to my sleep, my sleep sponsors.
Yeah, exactly.
I love that. So how does sleep play a role into the pain neuroscience education portion, right? How does that work?
Yeah. So let me tell you about one study where they kept people from sleeping. So they would, it was just sleep deprivation study. So they would start to fall asleep. They would wake them up. They kept them up. I don't remember exactly how many hours. We'll just say 24. And all of those people developed symptoms that were consistent with fibromyalgia, which is it's much more helpful to define in this term, in that they had body aches, they had extreme tenderness to palpation. So you're touching them very lightly, and their nervous system is perceiving that as a big threat. Like, okay, I'm touching you strong enough to like barely squish a grape, and you're having 6 out of 10 pain from that.
Yeah.
And so our nervous system can't function well when it doesn't have that sleep, because it over interprets a lot of those signals that are coming to it.
Oh, that's so good for people to understand, because essentially is what you're saying is your nervous system, this alarm system, becomes very sensitive when you don't get sleep, when you don't get adequate sleep. So all of these, 5,000 miles of nerves all of a sudden are giving signals to the brain saying pain, 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 when really these body aches that you're feeling are most likely you haven't recovered. You haven't slept. The body hasn't reset, right? So all of a sudden you have one little mechanical, maybe not even mechanical, right? But all these other factors playing a role, and you don't get sleep consistently, and then they just add up and you get more sensitive. What a beautiful study.
Yeah, there's another analogy that we could bring in here of, that nervous system being a cup. And there are lots of different things that can turn that alarm system up, make it more sensitive. Lack of sleep is one of them, so that fills that cup up. And then stress is another huge one. Stress and anxiety can fill that cup up to the brim so that any other signal coming in that might have been interpreted as a threat is now definitely interpreted as a threat. Or just anything in life. You're just moving. And it's like, oh, I'm just moving. But yet your nervous system is going, big alarm system here, like big alarm.
Yeah, and I love that cup analogy. And these are all tools that we teach our patients, right? This is what we call pain neuroscience education, is because when people understand this cup analogy, that your cup is already filled 95% with life. And then all of a sudden you start exercising on top of it, and you do a deadlift, and you hurt your back, it puts that overflowing, right? And it overflows, and that's what happens to break the camel's back, right? But was it the 5%, that deadlift, or was it the 95% of you're just overwhelmed and your body can't even function, and now you just put it over the top?
Exactly right. And that's what we've been talking about, right? Is all these other things.
So tell me someone, let's just give a few examples, like a young mom. She just wants to get to the gym. She wants to exercise. She wants to be strong. She's not getting sleep. Like life is just coming at her, and she just cannot physically get the sleep and take care of herself. What tips do you have for these types of people?
It is trying to structure your life, put the big things in first, right? Like there's another analogy where we have a jar of life and you put the big things in first. So putting in your exercise, putting in your sleep first into that jar, and then fitting in your family, obviously, and then putting the smaller things in. So, if there are other things that we can like reorder in life, and I don't have really specific examples without talking to this person, but we put those big things in first, and then we add in our small things after that.
And that's the biggest challenge. We have ChatGPT now. We have people Googling things, and I love the way you responded that I don't know how to talk to this person unless they're in front of me and I hear their individual concerns and their individual life circumstances, because we have to customize the treatment.
Yeah, absolutely. And it's not as much us doing that. It is us asking the right questions of the patient, and the patient is really coming up with a plan. We're just asking them the right questions to help them prioritize or help them plan. What are some other things that we could potentially offload or redirect in these things to make that happen?
Yeah, and that can be so challenging in a clinical environment, right? But it's really what creates lasting change is when we ask people, what is it that you need to offload? Rather than me telling you, oh, it sounds like you need to offload, you need to get more sleep, to a young mom that's like waking up all night. Like, well, yeah.
Duh.
Thank you for that, right?
Yes.
But when we ask the right questions as healthcare providers and we say, what do you feel you can take off of your plate? What is one thing that we can prioritize differently? Then you help people discover and be autonomous with their own life and help figure out solutions to their own problems.
Absolutely. Tell me about your day. First, seek to understand, right? So we need to understand what that person's day is like. And then we're asking questions, how important is this piece to you? That's really important. Great. We're going to put it in the jar first. Mm-hmm. How important is this piece to you? That's not that important. Awesome. Let's put it on this. Like we'll try to delegate or we'll try to change this list.
Yeah. Where do most people go wrong in this sequence? On the patient side, not on the provider side. Yeah.
Yeah. I feel like many people, and I definitely have been guilty of this many times in life, is that I'm just responding to things that are coming at me. Right? I haven't thought about all of these different categories and where their priority in my life. It's like, I got to do this. This came at me. Oh gosh, an email came in. I have to respond to this. Oh no, I probably should eat. And so we're responding to things as they're coming at us reactively versus proactively, versus like maybe making a schedule. And I know that doesn't work for everyone, but really thinking about what is important, prioritizing that.
Yeah, I love Stephen Covey's books. You've alluded to some of his terms, but we talk about urgent versus important. Or is it urgent or not urgent? And is it important or not important? Right? And you get on this quadrant and you figure out, where do I spend most of my time? You want to spend most of the time in the urgent and important category, right? If it's not urgent, but if it's important, then we're going to keep it here on the table with us, but let's put in the urgent and important things first and begin with the end in mind and say, what are the things I for sure need to get done today? Is it that urgent email that's alarming me on my watch? Is it that text message, or is it my kids in front of me?
Right.
Or the people I need to teach at school?
And that most distracting quadrant is that urgent and not important. Right? Because we feel like, oh gosh, it's urgent. Just like you're saying, talking about like your text messages, like, I'm pretty sure that person's going to be okay if I respond.
Yeah,
in 10
that
minutes.
solicitor that knocks on your door that says, it's only today.
Yeah.
The sale,
Yeah.
Memorial Day sale to get your appliances. It's only today, right? Yeah, it's those not urgent, not important things that seem to consume our lives sometimes and start filling the brim. You know, it's the comparison with the neighbor down the road or the other person at the gym that fills our cup in certain ways, right? It's when we're lacking sleep, our mental processing goes down. It's our nutrition, the way that we're eating, right? Let's dive into nutrition a little bit. How does nutrition play a role into back pain and just pain in general?
Well, just making sure we're getting adequate nutrition is a huge thing. So, and getting that in, there are no right proportions of those things between our macronutrients, which are like fat, protein, and carbs, but making sure that we're getting adequate a number of those. And a big portion of our population doesn't get enough protein and gets a whole lot of fats. And then thinking about
what's the general recommendation for protein?
General recommendation is about it ranges a lot based on your activity level. So for me, as an athlete trying to get stronger all the time, I get about 1 gram of protein per pound of body weight.
So if you're strength training, you're at athletic level, you're trying to gain muscle, that would be a general guideline.
And in general, somewhere around like 0.5 gram per pound of body weight would be sufficient, but really on the low end of sufficient. And we do have some evidence to say if you're getting less than...
So if I weigh 150 pounds, half of that, 75 grams of protein would really be kind of more at the minimum range.
Exactly.
Yeah, and I see clinically, barely. I mean, the majority of people don't even get the minimum protein levels. Right? What does that do to the human body when you're getting that deficient of protein?
Yeah, so as we're aging, we're losing a lot of muscle mass anyway, and so that process is going to be accelerated or at the top end of what we know it could be. And when you're the ultimate, fountain of youth, in my mind, is muscle mass and strength. Right. So if we're as strong as possible and we have an injury, we're going to lose some strength for a short period of time. Now, me, because I'll brag on myself a little bit that I'm fairly strong individual, I have a lot of reserve. I can lose a lot of strength before I'm going to lose some independence. But some individuals who are not as strong, when they lose even a little bit of their strength, they're going to start to lose independence. And then it goes downhill from there.
Yeah, totally. And it's wild how quickly you can lose strength. I mean, when I was in school, this was, I can't remember how many years ago, I was in an undergrad and I was doing a bed rest study with Bobby Briggs, Robin Marcus. And my job was to measure on an MRI the pre and post measurements of the study. So we'd get the thigh muscle up on a screen. I had this huge screen and I would trace around the muscle and we'd figure out exactly how much muscle mass was in that thigh muscle. and then we'd measure with force output on a plate how much people could push against it. So essentially, we were measuring strength. And in one of these studies, we put college students in bed for 7 days, so they could stand up to go to a bedside toilet, and they had to get back in. They couldn't take any steps for 7 days. And we measured their thigh muscle mass and their strength. And just in 7 days, the majority lost between 30 and 50% of their muscle strength, and up to like 3 pounds of muscle mass just in their thighs. And I'm tracing this. I'm like figuring out all these results. I'm like, oh my goodness. Just in 7 days, a young college student can lose that much muscle mass. And what does that do on a daily basis? What does it do when you're sick? Right? It's not that you actually lose it. You might hypertrophy that, right? We end up putting these people through a really robust strengthening program to get it back. And these young college students got it back fairly quickly. But it's just amazing that the body's job is to to break down. The reason for that is so it can repair and build back up. But if you don't give it the appropriate recovery of the sleep and of the nutrients that it needs to rebuild the protein, then it can't rebuild and regenerate again. Right? Is there anything you add to that?
Yeah, just that our body matches its stimulus, right? So if you're not giving it stimulus, if you're lying down, you're doing bed rest, or you're just sedentary, it is only going to be as strong as you ask it to be, right? So by asking it to do more, then
you gotta say that again.
Yeah.
You said it's only going to be as strong as, say the whole phrase.
Yeah, your body is only going to be as strong as you're asking it to be.
That's so good. So you're essentially the captain of your own ship. You're telling your body what you want it to do.
It is an adaptable machine, right? So it is fairly simple that stimulus is going to trigger that outcome. So if I'm not asking it to do much, it's not going to be able to do very much. Yeah. If I'm asking it to do a lot, then it will adapt. It will figure out a way to make that happen, and we'll get stronger.
For sure. So let's talk about number 3 on our list here. Exercise. What was the second part of exercise and movement?
Movement.
Because let's talk about this stimulus. It has to be, Wolff's Law states that, Wolff's Law is according to bones, right? So Wolff's Law states that if you add appropriate stress to a bone over a period of time, it will meet the demand, right? It'll change form based on the demand or stimulus you place upon it, right? And we could generally say that same term is for the whole body, but there's the appropriate stimulus, right? If we overstimulate it, what happens? We most likely get injured. If we understimulate, the body meets it there, right? So tell me about what overtraining does. Let's go more on that side first, because we kind of talked about that earlier.
Yeah, you nailed it already, right? So if we're asking a structure to do more than it has capacity to do, so we're asking that muscle to lift more than it has the capability to lift, it's going to fail. So maybe you strain that muscle, maybe you tear a tendon or something like that, but you get injured.
And then what happens when you understimulate it, but then you all of a sudden are going back in January and you're going to just go get after it?
Yeah, your brain remembers how strong you were, right? So, we've taken some time off, that your stimulus has been very low. And so your body's like, why am I going to spend all of the energy to maintain my strength when I don't need it, right? There's no demand for me to do that. So it starts to weaken, as our body does when there's no stimulus. And then you get back in there in January, and you're gung-ho about going after it, and you can for a short period of time, but then you're just running up against that body part's capacity. And
sometimes in our minds we're like, well, I used to be able to do X in high school. I used to be able to deadlift 380 pounds. I should be able to do that today, right? But I haven't done it in 3 years. What's the gap there that people really need to understand?
Yeah, your body is an adaptable machine, right? So anything that you're asking it to do, it is going to meet just that demand and not a lot more.
Yeah, it's really all about the consistency and frequency and volume of stimulus you give it consistently over time. And if you're not consistently doing that, it adapts extremely fast. And it doesn't mean that you're doomed to destruction and you can't just make it back, right? You can adapt fast the other way as well, right? We talk about, someone joins the gym, hasn't lifted in 10 years, and you see these huge gains, right? And then you have someone that's like an extreme athlete and their gains are like minimal. Tell us why that happens.
Oh, well, that's a lot of physiology.
Because you own a gym now, right?
Yeah,
Like
I do.
you see these new people come in and these like seasoned athletes are like, well, man, he just jumped 4 scales in like 6 weeks or maybe 3 months. And I've been working on my deadlift for 6 months and gone up 2 pounds.
Mm-hmm.
You know what I mean? But give us just the basic physiology behind that.
The basic physiology is that newcomer, that novice trained individual, they're not truly getting a lot stronger in that very short term. It's just that their nervous system, their brain is able to recruit more muscle in that very short period of time. So we're actually just dealing with, hey, I have more muscle doing the work, but I'm not actually building that muscle yet.
Yeah.
Versus that trained person has already gotten they've already gotten all those gains, right? They've gotten all their muscle working, and now they have to actually change their muscle. And so that process takes a lot longer for hypertrophy or getting that muscle bigger to actually happen.
Yeah, absolutely. So let's jump back into the clinic now. Someone has low back pain. We've done an exceptional job at talking about their sleep patterns, talking about their nutrition. We're working through the pain neuroscience, training their nervous system to be able to adapt. And we do that through exercise, through talking about it, through prioritizing things in people's lives, right? Why do we use movement in the clinic in collaboration with these other contextual factors? Like, why does a PT still have them come and do movement and strength training and all that on top of educating?
Well, we are the movement specialists as physical therapists, and movement exercise is a huge opportunity for us to improve our overall health. And health is not, we alluded to this earlier, but health is really not a destination. You're not going to get there and be like, oh, I made it. It is a journey. Mm-hmm. And so constant movement, a body in motion stays in motion. A body at rest will stay at rest. So we really need to train that movement. We as healthcare providers, physical therapists, will provide a lot of guardrails for patients as they're moving through from rehab to independence. And then, we'll help guide them beyond that. But especially in that early phase, we really need to be there and be in person, I believe, and help them move in a way that will be beneficial for them, provide correct loading for them, provide the correct exercises for them, and then some really good cues to move a little bit better. And we're not saying that, you're doing this on your own and you're going to hurt yourself. That's not really what we're saying. That there's a lot of opportunity for people to move on their own. But when there's a problem with some movement, we're the ones to help you with that.
Yeah. And the thing is, what I've realized, I've worked with people in pain, is that they'll start to move and it hurts. So in their mind, unconsciously and sometimes consciously, they'll say to themselves, the movement hurt, therefore exercise is something I should not do. It's dangerous, right? But movement is the best medicine in the entire world, right? There's no better medicine than movement and exercise, right? And that's why we use it in the clinics, is because it's desensitizing the nervous system, right? We're teaching them about these contextual factors that we talked about, but we're calming down the nervous system and we're getting it to move appropriately, get it the blood flow that it needs, the nutrients it needs, and we're also building mental resilience. We're getting people to believe that they can move and not do it in pain.
Yeah, I completely agree. I
wanted you to disagree.
No, there are many times where that is what's happening, that we're saying, and that's what I mean by guardrails. So thanks for cueing me to expand on that. Is this movement is okay. This amount of discomfort that you're feeling is okay. It's expected. There may be other times where we're saying, you're not ready for this movement yet. if you continue this movement this way, that might actually injure you. And so with our biomechanical background, with our exercise physiology background, we know which those two are. And so providing that information to patients can really help. And I've had many patients who say, oh, that pain's okay. Okay, good. I just didn't know.
Yeah.
And now I can move through that. I feel okay with this because we've de-threatened that movement.
Yeah. And a lot of times people just need the permission to say, that is what you work through. That is what you don't.
Yep.
Right? Because people don't know what their body is telling them. And as exercise specialists, that's our job. That's our job to say, yes, that's what you listen to. This is where you is a check engine light, and this is proceed with caution. And this is a green light, right? And, I try to never tell people don't do it, right? But I try to, just like what you say, give them guardrails. It's like, well, you're going to bump up against that, right? Mm-hmm. It's your choice if you want to go there. If you're going to go there, I was guilty of this in motocross, right? My doctors would always tell me broken arms. Like one time I remember I was in a championship and I had like 2 races left. I broke my thumb and my wrist and I had to have external pins placed in it. And then I had a cast over the top. And my doctor said, no riding for 6 weeks. And in my mind, I'm like, I am in a championship. Like I'm going to win this championship. There's no way I'm not riding. And I remember I said something along the lines, can I like tape it to my bike? And he's like, absolutely not. Right. And what do you think I did? I'm like, I'm taping that to my bike, right? I remember I have this picture, and maybe I'll post it on this podcast, but I'm whipping sideways, and I'm pointing to the crowd with my broken hand in a blue cast, like this. Actually, I can't remember it was this hand, but yeah, it's pointing like this. And like, I hope that there's healthcare providers that say, what is it that you want to do? And how can I help you be as safe as possible? And help you understand the issues if you don't follow these recommendations, right? I would have loved that, but teach me how to do it safe. You know what I mean? Is there anything you'd add to that?
No, I love that. And yeah, I can totally identify with that as well. But I'm exactly the same way, and teach our students to be the same way, that we're very, very rarely saying, don't do this. Right. And when we're providing more information. Don't do this for right now. This is a pain that we don't want to work into. This is a pain location that we don't really want to expand into. And then there are other cases where we're saying, this pain is actually good. That's very rare, but this one is the one that we're after to know we're in the right optimal zone of loading for you.
Yeah. And, a lot of the public doesn't understand the in-depth studying and education that we receive to know when to make these calls. And there's just so much to it. You have a doctoral degree, a fellowship, which is how many years? Your fellowship?
3 years for fellowship. Yeah.
So we're talking undergrad, 4 years, 3 years doctoral, 3 to 4 years fellow, and then PhD is what?
That varies a lot, but mine was 5.
Right.
Yeah.
So, we're talking a decade and a half, almost 2 decades at studying this very in depth and understanding it very well. And we can learn it on Google, right? Let me just Google it, right? Mm-hmm. But there's just so much to know and so much we have to break down and help people through their journey. And that's why we see them as much as we do, is because we want to help you through this injury and through better health in the future as well. So knowing that, I want to kind of segue into this new primary care role, primary care providers in Utah. We've talked about this on the podcast before. You're a huge advocate for it in the classroom and in your clinic. Tell me what you feel that it means to Utah to have physical therapists now as primary care providers for pain and injury.
If there was one thing that I could change about physical therapy or healthcare in this country to improve people's lives, it would be removing the barriers to get to us, right? And by having us in that primary care role for musculoskeletal injuries, that removes that barrier. Our typical process, and not everyone has to go through this process at this point, but the understood process is that you go see a doctor first, a physician first, and then they may do some imaging and then recommend that you go to physical therapy. well, how long is it taking to get into our physician or primary care, considering that we were just talking about this before the podcast started, that we are not in a great position in Utah from the number of primary care physicians that we have. We're 49th in the nation on in having a number of physicians. So the access to those is a huge barrier. You're going to wait 4 weeks to get into your physician, and then you're going to wait additionally to get into your physical therapist in many cases. But if you could just go directly to that physical therapist, that's a lot of time that you could have saved yourself in being in pain or not doing the things that you wanted to do.
Yeah, absolutely. We check her audio real quick. I just want to make sure. She's kind of leaning to the side, so I want to make sure so it's good. So with that said, how does this bill change Utah's ability to get access?
Yeah, it removes that middleman that's just not needed. So not having to go to our primary care before we go to a physical therapist is just huge for our patients.
Yeah, tell me about if the people that are worried about doctor of physical therapies having the knowledge to be able to treat their condition before going to a physician.
I understand the concern because we've talked to many research participants about like, hey, what were you thinking when you first had this back pain? And a lot of people are thinking that something must be really wrong with them, right? Like, I must have a tumor. I must have a broken back. It hurts that badly. And I've had that kind of back pain where I'm like, gosh, this just reordered my 0 to 10 pain scale. And wanting to know that, like, I know that I'm not going to hurt myself by going to a physical therapist. And those are some of the current concerns that people have. And I don't think that people understand that we spend a whole lot of time educating our students on how to recognize when that person does not belong in front of you. When they belong somewhere else, we are going to recognize it. Can we identify your cancer? No. But we know when you don't belong in front of us, and we'll send you to the correct provider to figure that out.
Yeah, I was talking to the PT students about this just a few days ago, and that's the key. That's the key to a primary role, is knowing when something is not right. Can we identify the cancer? I can't identify that that's cancer, but I know that you're not in the right office, and my job is to get you to the right office. But 85% of the people that come off the streets are in the right office. We just got to remember that. Right?
Absolutely.
But then we have to identify the 15% that's like, this is not responding in the typical fashion of how it's supposed to. Therefore, I'm going to order an MRI. I'm going to order an x-ray, or I'm going to get you to a specialist within this area. And that's what it's about. It's not being an expert in cancer. It's not being an expert in all these other factors that we need to consider. It's about knowing when it's not right.
And I think a lot of people can identify, relate to, I do something so often that I could do this in my sleep. And so as physical therapists, we do musculoskeletal pain day in, day out, years and years. And so when something's not fitting musculoskeletal, we know it. Like, we know when that happens. And does that mean that we can fix all musculoskeletal pain? No. And we don't ever proclaim to do that. We will send you to the correct provider when this doesn't work. But if you go to that provider, that next step, too early, you're much more likely to get other procedures that you don't need, injections, surgery, medications that you don't need, and will actually harm you in the long run if you're not in the correct place first.
Yeah. The thing is, like, I just don't understand how we've ever gotten to the point where we are, where people just make the decision on their own, the public, that I just need to go to see a surgeon. It's like, that's like the last step. That's like step 27 in the recipe here. Step 1, go to a PT, right? Or step one, maybe look at your sleep, your nutrition, like your life and how overwhelmed you are. That's step one, right? Identify that you actually need to do something about it and then get some help. But ultimately, we're the least invasive out there. There's really no harm that we can cause a patient other than maybe pushing them too hard, but ultimately that's why we're the entry point, is because the majority of people just, I'm doing a talk on shoulder pain soon, and I've identified that around 83% of people get better with PT and not needing further intervention, right? So just knowing that statistic alone, it's like, well, 83% get better. Why wouldn't you want to start with us? It's the cheapest. It's the least invasive. It's the most important to exercise. It's the, if anything, it's going to help you, even if you do need surgery, right? It sounds like a win-win to me, right? But ultimately, that's where we got to start, right? What would you say to the young clinician that's just a little bit worried about being a primary care role?
Oh, our young clinicians are so well prepared to handle this. I understand that you want some sort of safety net to be there, but I also want to empower you that you don't need that safety net. You have all of the tools at your disposal in your brain to handle a primary care role.
Yeah. I'll tell you one story real quick, and then I want to jump into why we have to walk the walk and live that lifestyle as well as providers. I had a patient come in. I told the students about this the other day. Just young gal, 43-year-old gal with low back pain. And she was super young, looked super fit from an external point, right? She had some cultural factors that were challenging and some language barriers. But we got 4 or 5 visits in, and I treat a lot of low back pain, and I know when something's not going right. We were, I think, our 5th session in, and she came back, 4th session, a little bit better, right? And she was just debilitated. Her husband was like linking arms with her as she's walking in the clinic, kind of carrying her in and out of the car. And for the most part, that was fairly normal for an acute low back pain. But we got to the 5th visit, and she said something that really was like alarm. She said, I was up with my girlfriends last night, and we were laughing all night long, and I am in extreme pain now. And in school, we learn about this Valsalva, the pressure, right? And she could barely move. She couldn't move her pelvis. She could barely walk in. Her leg symptoms were crazy. So I just said, this is not following the normal sequence. We're just going to order an MRI just to make sure everything's okay. And we'd ruled out that she did not have any bowel or bladder symptoms. She did not have any problems sleeping at night. She slept like a baby, right? There's all these other factors. And she actually didn't have any leg symptoms at all other than just pain. So, I'd ruled out some of these, what we call red flags. And then we got this MRI. The radiologist called me on the phone before the patient left and said this patient has 17 pathological fractures. So meaning that some sort of tumor has invaded the bones and weakened them, and there had fractures all up and down her spine from her mid to low back, and she had tumors embedded in all of them. And there was an unstable fracture at a certain level in her lumbar spine. So as a primary care role now, it's my job to make a decision. What do I got to do? Right? And the radiologist said, what do you want to do? They're leaving, they're getting in their car, unstable fracture, right? So long story short, called the patient, sent them to the emergency room, and we carried that journey on. And I wish I had a better outcome. Unfortunately, she ended up passing away about 5 months later. But ultimately, that's what it's about, right? It's about identifying when something's not right. And we do this day in and day out, and these students, they are prepared, and they do want that safety net, but this stuff, and you'll know when something isn't wrong. And you hopefully have people around you too that you can bounce off of to validate when it's not going wrong. It's like, yeah, that's not right, and it is rare to have not right things, because the majority are they're in the right spot, right? But you got to be able to identify those ones that are not.
Yeah, totally agree. It's great catch. And it is, like you're saying, it's not that hard to make those catches. It may have taken any clinician 2 more visits to make that call, but those 2, 3, or if you had seen it 2 visits earlier, was not going to make a big difference for that patient.
Yeah, absolutely. So let's talk about, we'll kind of wrap up this podcast in the living the way we talk to our patients. You've had low back pain before, right?
Yeah.
What do you do when you're in an injury? Like, what do you do in life to make sure you're living what you teach?
Yeah, great question. So, as a CrossFit athlete, I'm probably pushing the envelope on what my body can actually handle.
Almost maybe to a dangerous level.
It is, yes. It's not always to like the optimal health level, and so I don't advocate that people do that. And again, we're not trying to get people to run marathons as far as movement, but we do need them to lift weights, and we needed them to get some aerobic exercise. And patients will look up to us. They will see how you're living your life. They will see the way that you speak to others. We're not talking about just like exercise at this point, but patients will look up to you, and taking that responsibility as such is important. I forgot the rest of your question.
The whole idea is like, how do we demonstrate that we're walking the walk? I love that you talked about not just exercise, but how we treat people, who we are as a human being. And why is it so important for a patient to be able to see that?
Yeah. The other thing is like how we're talking to ourselves, right? So like when I have an episode of back pain and I'm like, something has got to be really wrong.
I'm going to get an MRI.
I have all of this knowledge, and I'm not immune to like catastrophizing, making something bigger than it is, or thinking that this one symptom means something terrible. Like I'm not immune to that. But how I talk to myself in those moments are some rationalization, like, this is okay. That this is going to be okay. This is ordinary type of back pain. You're not having these symptoms, and that's okay. And being graceful with myself as well. Like, it's okay that you're thinking this. This is what patients think all the time. And in terms of like talking to myself gracefully, which I feel is important, is I'm not tied to my patient's outcomes either. So like we're talking to physical therapists now, right? Like, you're not in charge of that. You're in charge of doing the best that you can. And sometimes patient outcomes are in patients' hands. We provide the information that we can. They have to utilize
There's some action that needs to happen. Yeah, this is in your core, the things that I'm teaching you, and it's how you actually follow through with them. A lot of people just want the quick fix. But ultimately, what we do is lifestyle medicine. It's changing habits within life. And sometimes that's really challenging. And it's not that PT didn't work. It's that the implementation, the execution of what we taught or what we did didn't happen. And that's why it didn't get better. It wasn't carried through.
And it may not be the patient's fault at all. So I'm definitely not saying that. Patients need to give themselves grace as well. I'm doing the things that I'm supposed to be doing to fully explore whether physical therapy can really help me. Yeah. And if it can't, that's okay. I have other steps that I can go to. But what you would really regret is going on to those other steps when you didn't really give the first most conservative care its really due diligence.
Yeah, absolutely. And I think, people, they often will, it's rarely what you hear, right? It's more of what you see and feel. Like as a provider, if I'm not walking up to the standard that I'm providing for them, it's essentially hypocritical. It's hypocrisy, right? In my mind, it's like, well, I'm giving you these guidelines, but I'm not doing it myself. It's like, you need to be sleeping 8 hours a night, but I'm getting 5 all the time, and I'm constantly tired, and you can see that, right? So what I'm saying is, it has a lot less weight, right? Because they're like, well, you're not really doing it. It's never a verbal conversation, but internally, we can see it, we can feel it, right?
Sure. How important is it if you're not actually doing it?
Yeah. Like you're saying it, it's one thing, but you're not actually living it, which is another.
Do we really listen to those people that say, just do as I say and not as I do?
Yeah, exactly. Mm-hmm. And a lot of times we never verbalize it, but we're like, I don't know if I trust that. Mm-hmm. And that's a lot of the reason why, right? Sure. Any other last tips for people? Let's just talk about when you go through back pain. Say you injure yourself. You've done this recently?
Sure. Yep.
Yes. When you have an injury, what are the things that you're thinking about? You alluded to some of them, right? That internal talk, not catastrophizing or thinking, oh, everything's going to, I'm going to need surgery, right? You're not automatically going through those things. What are the things you're thinking about? What are the steps you go through in your mind to kind of get back to full function?
Yeah, those first few steps, the first step is not intentional step, but the first thing that happened is maybe some of that anxiety and like chaos of the injury and like, oh gosh, I'm not sure this is ever going to get better. And all those things are okay, pretty normal to think. But pulling back,
I love that you address that and say that's pretty normal to think, even for someone like an expert like you that spent decades in education and understanding low back pain.
Yeah, it's okay to think. Give yourself, the grace. It's okay. Because things can spiral out of control if you start to worry more about that. Taking some, and then taking a step back, allowing that chaos to calm down a little bit, and knowing that most of these things get better. You've had this experience before. I've had multiple injuries and experience to draw from, and that things never stay this bad for this long. So things are going to calm down, and then we need to address some of the reasons that this may have happened. And it is fairly methodical at that point. This body part is on fire right now. Let's get that fire put out. And then
fire extinguisher.
And then let's take care of some of the reasons that this happened and some reflective practice of like, what really led to this, is most often it's a training error that I'm like, yep, you did this on this day. And then you did this on this day, which were too close together. Or many times, especially in my life, it's you really didn't eat enough in between, or you were super stressed about this going on in life, and that filled your cup up too much. And so that's what caused it to overflow. And so, identifying those things makes you smarter for the next round.
Yeah, absolutely. And it's hard not to panic. It's hard not to be worried about the future and, oh, I got to get back to my job and I got to be able to, train for this next competition or whatever it is. But ultimately, I love what you say is like, just keep building. It's going to come back. The majority of these injuries do go away as long as you treat them appropriately. If you feel like you're stuck, find an expert that can help you through it, right? Because that's what healthcare is all about, is helping people through their health, right? Caring for their health, and finding a provider that can really be compassionate and understanding, ask the right questions, help you develop a plan, help you see areas or blind spots that you have, and then get you through the movement, desensitize that tissue, teach you what gaps you have in your knowledge, and then build your capacity and resilience again. We're absolutely resilient humans. Like you said, it's a machine. Our body is a machine. It's adaptable. And if we continue to develop it the right way, give it the right nutrients, get the right rest, recovery, it does extremely well for us.
Absolutely right. Father Time is undefeated, but the place where we start, before we start, the higher we are, the stronger we are, the more mobile we are, before time gets to us, we're going to end up in such a better place.
I love that. Well, thank you for joining us on the podcast today, Elizabeth. This has been a joy to discuss all these different factors. It is multifactorial. There are so many things that play a role in pain. I love that you identified it as sleep, nutrition, exercise, and movement. Those are really the three pillars to pain. If we can master those, that's where we should spend our energy, not on these other, 1%. I'm not saying that saunas are bad. I'm not saying that massage is bad or any of this compression type, ice stuff. But we got to remember that the normal ways to recover is sleep, nutrition, and movement. So I love that. Thanks for joining us today.
Yeah, thanks so much, Brent.